We are delighted once again to welcome Professor Duygu PERÇİN to present her findings. You'll be all glad to hear. You'll hear a lot more of Professor PERÇİN than you will of me in this presentation. Just a very brief word of introduction. My name is Kieran McBrien. I'm part of the foundation team of Novaerus, and I'm generally responsible for the development of international business. I would like to say, once again, formally welcome to everybody. We've a lot of people joining us from all around the world, as we had in the seminar last week. So we have people from South America and Latin America. We have a very impressive contingent from the United States of America, I'm glad to say. And we have a lot of people joining us from other places, but also from the GCC countries. So to them, I would like to say Salam Alaikum. To our people in Central and Southern America, Buenos Dias. And of course, welcome and hello to everyone else. I think you'll enjoy the presentation. There's some extremely interesting data which we will present. Just perhaps one word before we go any further for our North American friends and colleagues. During the presentation, in all cases, we will be referring to Novaerus. We are referring to Novaerus Devices, which is the brand that we use outside the United States of America. Inside the United States of America and North America, obviously, the devices are WellAir, but they're the same devices. And Novaerus is a WellAir Solutions brand. So I think that's most of the housekeeping. Slaney, let me introduce my colleague, Slaney Arias, who'll say a few words to our Latin American and South American friends on the housekeeping side. And then we'll get into, as it were, the meat and potatoes, so to speak. Slaney.
Thank you, Kieran. Buenos días, buenas tardes a todos. Estamos muy contentos de tenerlos por aquí en este webinar. Solo para comentarles que al final de la presentación de la doctora PERÇİN vamos a tener una sesión de preguntas y respuestas, por lo que los invitamos a que escriban sus preguntas en la cajita del chat y al final de la presentación las iremos contestando. Y por último, comentarles que hay una opción en la parte de abajo de cuando la doctora PERÇİN empiece a compartir su presentación, van a ver 3 puntos. Si le dan clic a esos 3 puntos, van a poder ver una opción de traducir las diapositivas de forma automática en diferentes idiomas, incluyendo español, por si desean hacerlo. Muchas gracias.
Thank you, Slaney. So, delighted, as I said, to welcome Professor PERÇİN. A few words about Professor PERÇİN. She qualified in medicine in 1992, specialized in clinical microbiology in 2000, and since then has been involved in a great number of international research projects with national and international collaboration, dealing with bacteriology, healthcare-associated infections, and sterilization. And of course, that's why we're delighted to have her here today. She's currently the Vice Rector of Cotaya Health Sciences University and the head of the Department of Medical Microbiology in the Faculty of Medicine in that university. Also dean of the Health Sciences faculty, where hundreds of nurses, midwives, and physiotherapists graduate every year. She's president of she's got a whole list of things to say about her. We could talk about her all day. She's president of the DAS, which is the Turkish Society for Disinfection, Antisepsis, Sterilization. And she's also an executive committee member of the World Federation for Hospital Sterilization Sciences, the WFHSS. She's been involved in a lot of peer-reviewed studies, publishing themselves and also as a reviewer. And we have been in contact now, Professor PERÇİN, for, it must be, how time flies, the best part of 3 years. And I know I asked you I've asked you before on more than one occasion. Do you remember our first conversation when we did the presentation on all of these subjects with Professor Axel Kramer, who was president of the German Society of Hospital Hygiene? And I think it's fair to say you were a little bit reticent about the whole subject of possibly using air disinfection in a study like this. It'd just be interesting before you get into the whole situation. I'm not trying to interview you or put you on the spot. Just would be interesting to see what your do you remember that conversation and what your views on it now might be?
Yeah, I remember that conversation. It was really a nice talk with your team and Axel Kramer, and it was really interesting. But you remember my hesitation also, because we were always walking with the CDC guidelines and saying no need for air disinfection, just surface cleaning and everything. But in the end, I said, I'm scientist. If I call myself scientist, I should be impartial, and then I should see it myself. I should make the research myself. So I decided to go on with this study, and we contacted you, and then the story is there. So everybody will hear the story now.
Yeah, we hear the story now.
End of the study.
Yeah, I had to go and buy myself a new desk after that study because I took so many bites out of my desk. It was no, I'm just kidding. It was the start of an interest, and of course we're working with Professor Kramer on a number of other studies as well. So I think without any further ado, we'll hand over to you. I will, to everyone's delight, disappear for the moment. I think just one more thing. Anyone has questions in the course of we'll deal with them at the end, but we would welcome you submitting any questions in writing through the chat, and we'll try to do them in chronological order at the end. So over to you, Professor PERÇİN.
Thank you very much, Kieran, for this nice introduction. I'm really excited to be in this webinar, and especially the group of Latin American colleagues that I'm very happy to present today to them. So as you introduced me, I'm coming from Turkey, and we did a very nice study with together with my colleagues. And I'm working in Kütahya, the west part of Turkey. So I want to give a small overview about my city. The city where I come from, Kütahya, is located in the west, as you can see on this photo, and it's very famous for its handmade tiles, really beautiful handmade tiles. Then the historical sites of the Phrygian Valley and Izoni Roman antique city are nearby. And Kütahya is also very well known for its natural therapeutic hot springs. So if you want to treat yourself and spoil yourself with the hot springs, then you should come to Kütahya. It's where you should be. So if I start my presentation, I want to start with this quote of Rutala, because I like it very much. It says, whenever patient care is provided, strict adherence to evidence-based infection prevention guidelines is essential to ensure that all care is safer care. Of course, it's not only Rutala saying it, also all professional infection control doctors and nurses, everybody have a consensus about that. We need evidence-based infection prevention guidelines. Because it's estimated that each year in the United States, of the 1.7 million hospital-acquired infections, 99,000 results in death. And 20 to 40% of hospital-acquired infections can be attributed to cross-infection via the hands of healthcare workers. And healthcare workers' hand contamination can result in two primary ways: from direct patient contact or indirectly from touching contaminated environmental surfaces. 20% of hospital-acquired infections may occur when a patient becomes colonized by direct contact with contaminated environmental surface. In this slide, you can see the points where an indicator microorganism can be recuperated in close patient areas in the intensive care unit. It is not difficult to imagine how important the patient's environment is. You should also keep in mind that all kinds of microorganisms, you can include SARS coronavirus 2 here today. I added this table from Stephanie Tenser, that's SARS coronavirus. That's all kinds of microorganisms can survive from hours to days on inanimate surfaces, which increases the risk of cross-contamination. Bundles are very important for infection control at hospitals, and there is also one for environmental cleaning and disinfection. Hospitals must develop policies and procedures, select cleaning and disinfecting products, educate staff environmental services and nursing, monitor compliance and feedback, implement no-touch room technologies, implement no-touch decontamination technology. It should be kept in mind that no-touch technologies supplement but do not replace surface cleaning and disinfection. There are some chemical no-touch disinfection systems that you can see the summary on this diagram. And these are mostly used for terminal disinfection, for example, after discharge of a patient on contact precautions. And UVC is another technology used to no-touch rapid disinfection. There is no need to close the heating, ventilation, air conditioning system as in the case of chemical disinfection, but the problem is direct exposure is mandatory for efficiency. And there is also another advantage of UVC that patient can enter immediately after disinfection. That is not the case in chemical disinfection. Continuous room disinfection technologies are becoming more and more a trend, such as visible light disinfection through LEDs, dry dilute hydrogen peroxide, self-disinfecting surfaces like copper, far UVC, bipolar ionization, multi-jet cold air plasma, and as in the case of Novaerus, continuously active disinfectant, and as in the case of Novaerus, 24 hours air disinfection by using air discharge plasma. CDC and HICVAC have recommendation in both 2003 guidelines for environmental infection control in healthcare facilities and the 2008 guideline for disinfection and sterilization in the healthcare facilities that state that the CDC doesn't support disinfectant fogging. These recommendations refer to the spraying and fogging of the chemicals as a way to decontaminate environmental surfaces or disinfect the air in patient rooms. These recommendations do not apply to the newer technologies involving fogging for room decontamination, for example, ozone mist, vaporized hydrogen peroxide, that have become available since the 2003 and 2008 recommendations were made. These newer technologies were assessed by CDC and HICVAC in the 2011 guideline for the prevention and control of norovirus gastroenteritis outbreaks in healthcare settings, which makes the recommendation more research is required to clarify the effectiveness and reliability of fogging, UV radiation, and ozone mist to reduce norovirus environmental contamination. CDC does not yet make a recommendation regarding these newer technologies. For the approval by the CDC, they must be evidence-based, as I told at the beginning of my presentation. So, in fact, the purpose of our study was to look for the evidences, to be able to investigate the evidence and clarify the effectiveness of Novaerus air purifying system. We performed an interventional prospective study and I'm going to share this study with you in the rest of my presentation. This study is published already online in Journal of Hospital Infections, and you can easily download it because it's open access. You can download it also through the invitation letter you have received. And I must declare here that we have no conflict of interest, because for the study we received the devices, various devices from the company, but we sent them all back after the study is over. We didn't keep anything. We didn't receive any fund or whatever, neither the hospital nor the investigators. So as you can see on this article, it's a multidisciplinary study, and we received contribution from Public Health Department, Medical Microbiology, Infectious Diseases, and Anesthesiology and Reanimation departments. Of course, the patients were hospitalized in the intensive care units. The study was performed in Kütahya Health Sciences University Evliya Çelebi Research and Training Hospital, which is a general hospital with 950 beds, 119 intensive care unit beds. The most common hospital-acquired infections in Turkey include pneumonia, bloodstream infections, and urinary tract infections, with the most common agents being Pseudomonas aeruginosa, Acinetobacter species, Staphylococcus aureus, and other Pseudomonas species. When an ICU patient infected with these microorganisms resistant to the antimicrobials, their stay in hospital is prolonged and their treatment costs are increased, causing higher morbidity and mortality rates. Immediate preventive measures to minimize the entry and spread of resistant microorganisms in hospital settings should be the first step in the fight against these infections. Appropriate and effective operation of heating, ventilation, and air conditioning systems is a priority for improving the environmental factors that affect the indoor air quality of hospitals. High-efficiency particulate air filters are recommended for infection control in high-risk areas. These technologies can efficiently filter all kinds of aerosol particles regardless of their biogenic origin, as required by the applicable standards. Many studies have reported that HEPA filters in hospitals can reduce the risk of Aspergillus and other fungal infections. The literature also reports that HVAC-integrated air filtration systems may decrease aerosolized viral loads. Air filtration such studies also suggest HEPA can be very useful for reducing airborne levels of COVID-19 SARS coronavirus 2. Therefore, by protecting and reinforcing existing ventilation systems by means of hospital environmental and administrative controls, we can minimize the rates of hospital-acquired infections associated with airborne infectious pathogens. The objectives of this study were to determine the indoor microbial load inside the ICUs and the immediate surrounding of ICU patients, and to evaluate how effective the air purifiers installed in the ICUs are in filtering microbial load and preventing ICU infections. This was an interventional study that was designed prospectively between May and November 2020. Two general types of ICUs with similar bed capacities, patient requirements, room areas, and previous year's hospital-acquired infection rates were selected for the study. These ICUs shared a central HEPA filtration system with the room temperature maintained at 20 to 25 degrees Celsius and a relative humidity of 30 to 60%. As you can see in this, on this floor plan, they are located on the same floor, opposite from each other, both ICU 1 and ICU 2 were 105 square meter and had 8 beds each. But as you can see on this this floor plan, one of the beds were isolation beds. So this was totally isolated from the other main ICU beds. And in the first half of 2019, the rate of hospital-acquired infections in the ICUs at the study hospital was 1.47%. The study consisted of 2 phases, as you can see in this diagram. In phase 1, ICU 1 was the interventional site, whereas ICU 2 was the control site. The air purifiers in the interventional ICU were placed far away from doors, windows, and ventilation system. They were used for 2 months, and then the device was turned off, followed by a 1-month waiting period that was in August. The air purifiers were placed in the ICU, which was the control in the phase 1, after the filters were replaced completely. The previous intervention ICU became control ICU in phase 2. Phase 2 of the study was then initiated for 2 more months from September to November. And in both phases of the study, the facilities were maintained through routine cleaning procedures that the floors and all compatible elevated environmental surfaces were cleaned using 1000 ppm chlorine-containing disinfectant 3 times a day, and 70% alcohol was used for the chlorine-incompatible surfaces. The central HEPA filtration system was used in both ICUs. For this study, Novaerus air purifiers were used. The Novaerus Defend 1050 has been cleared by the FDA as a Class 2 medical device to filter out and inactivate airborne virus and bacteria within large rooms and indoor spaces. It's a freestanding, portable, recirculating air cleaning system with 5 different airflow speeds. The device has ultra-low energy plasma technology, a highly powerful yet extremely gentle method of rapid pathogen destruction, combined with the high-performance multi-stage filter system from Camfil, which consists of 3 different filters. Novaerus 800 is a stand or wall-mounted device with 2 speed levels. This study used one Novaerus 1050 at speed level of 3 with 267 cubic meter per hour airflow and 67 decibel noise level, and 2 Novaerus 800 model devices at speed level 2. The washable filters were cleaned every week, and when transitioning to phase 2 of the study, all the filters were replaced. Filter neutralizes the volatile chemicals, odors, and impurities. A Camfil HEPA filter traps bacterial debris and particles as fine as the 0.12 micrometer. And 6 nanostrike plasma coils, as you can see on this the lower photo, these plasma coils provide deadly strike made up of multiple concurrent inactivation processes which work to rapidly destroy airborne pathogens. The source of plasma is the coil assembly that is surrounded by the atmospheric plasma discharge. The Defend 1050 has been independently tested and shown effective against a surrogate virus for SARS coronavirus 2, reducing the virus by 99.99% in 15 minutes. Many air cleaning methods in use by healthcare facilities rely on filters to capture the pathogens, but without deactivating those pathogens first, the filter can allow viable microorganisms to colonize. The Novaerus plasma technology solves that problem by killing airborne pathogens before they become trapped in the filter. Microbial load concentrations in the air were measured using the bioMérieux Air Ideal 3P air sampler. The air samples were collected at 5 different designated points inside the ICU. A total of 500-liter air samples were collected using the sampler at a steady rate of 100 liters per minute in each sample, with 100 liters collected at each point. A 5% ship blood agar was used for sampling, and an aerobic bacterial count was performed. Quantitative results were provided in terms of number of colony-forming units per 500 liters of air. Swab cultures were simultaneously collected from an area of 10 square centimeters of high-touch surfaces, including the bed armrest, bed headboards, bedside monitors, overbed table, nurse desk, and medical cabinet in the ICUs. We used dark-room swabs that were moistened before this swabbing. An aerobic bacteria count was performed, and the results were presented as colony-forming unit per 10 square centimeter. Samples were collected in the same way before the device turned on day 0, as well as on day 7, 14, 30, and 60 of the operation. And the same procedure was followed to collect samples in phase 2 of the study. A total of 120 air samples and 240 surface samples were collected over 4 months. The number of patients with diagnosed hospital-acquired infections and the rates of the hospital-acquired infections during the study were calculated for the interventional and control ICUs. The same infection control doctor who is not involved in the study conducted the routine surveillance for hospital-acquired infections throughout the study period. And hospital-acquired infection diagnoses were made based on European Centers for Disease Control and Prevention criteria by using the formulas you have seen on the slide. The presence of any microorganism causing any indicator microorganism, of course, causing hospital-acquired infections in the ICUs, including Staphylococcus aureus, Enterococcus species, Enterobacteriaceae, Pseudomonas species, Acinetobacter species, and other non-fermenting gram-negative bacilli was investigated. The presence of any antibiotic resistance in Enterococci and like vancomycin resistant in Enterococci, methicillin resistance in Staphylococcus aureus, or carbapenem resistant in Enterobacteriaceae were examined. And here are the results. In this table, you can see the distribution of pathogen microorganism species detected in the interventional and control ICUs on the sampling days in the first and second phases of the study. As you can see on this table, they are mostly Acinetobacter baumannii and Klebsiella pneumoniae and Staphylococcus aureus. All Acinetobacter baumannii strains were found to be resistant to carbapenem and tigecycline and susceptible to colistin. Staphylococcus aureus strains were susceptible to methicillin. Klebsiella pneumoniae strains were resistant to carbapenems and, with the exception of one, susceptible to colistin and tigecycline. Carbapenem and tigecycline resistant but colistin susceptible Acinetobacter baumannii and carbapenem resistant Klebsiella pneumoniae were the primary pathogens causing the hospital-acquired infections according to the infection control surveillance data. The evaluation of the change in the interventional ICU over time revealed a significantly lower colony concentration in the air and on the surfaces on day 60 compared to day 1. An evaluation of the change in the control ICU over time revealed a significantly higher colony concentration in the air and on surfaces on day 60 compared to day 1. The colony concentration in the air in the control ICU on day 1, 7, and 60 was significantly higher than that in the interventional ICU. The colony concentration on surfaces was significantly higher in the interventional ICU on day 1 and a significantly higher colony concentration was found in the control ICU on day 7 and 60. In phase 2, the evaluation of the change in the interventional ICU over time revealed a significantly lower colony concentration in the air and on surfaces on day 60 compared to day 1, as in the case in the phase 1. The evaluation of the change in the control ICU over time revealed a significantly lower colony concentration in the air and a significantly higher colony concentration on surfaces on day 60 compared to day 1. This is the most striking result of the study that indicates the difference very well for me. So the blue shows the control ICU results, and the yellow, the green shows the interventional ICU results. So as you can see here, the first part from May to July, it's the first phase of the study, and August is the break period that we stop all the devices and we continue with the routine. And from September to November, you see the second phase of the study. So you can see here the rate of nosocomial infection in the first phase goes up almost to 5 in control ICU in that term, although the median is 1.5 in the previous years, but it of course in intensive care units the infections are wax and wane over the time, so this can be explained by this change. So the intercontrol ICU, the rate of nosocomial infections are going up almost to 5, while in the interventional ICU it's going down to almost to 0. At the break, it comes both ICU comes to the point of 3, and then in the second phase, in the control ICU again, it goes up, and in the interventional ICU, it goes down to 0. So it's I mean, if I was seeing this result for once, I would really consider that it's just coincidence. But when we repeat and we find the same result, so I cannot explain it with coincidence anymore. So there was a significant positive correlation between the number of colonies and the rate of hospital-acquired infections in both ICUs, as you can see on this graph. There were some, of course, shortcomings of the study, although the ICUs in the study were selected so that both had the same characteristics, and we tried to collect the microbiological samples when there was no activity. Some situations were beyond our control, such as staff activities, consulting physicians' activities, patient movements, curtain movements during emergency procedures, and the fact that during some procedures, air purifiers were behind the curtains. So we were going back to the ICU to check if everything is all right, and we were finding that the device just behind the curtain, that is that the airflow is completely prevented. But I mean, we were putting everything back to order. But next time, that was another story. It's a normal ICU, as everybody knows. We arranged for phase 2 of the study to exclude these factors and swept the control and interventional ICUs operating the device for another 2 months. Although the measurements were taken simultaneously, it should be noted that these samples were collected instantaneously, and there may be some instantaneous differences in the ICUs. We completed phase 1 of the study in summer and phase 2 in autumn. The effect of the seasonal air should not be overlooked. The conditions in the ICU, such as COVID pandemic, patients turnover, personal number and their movement, the seasons, unintentional prevention of air filtration devices flow by curtains or patient's bed position, or extra devices used for the patient were totally uncontrollable. Quick turnover of the patients could not be prevented due to the excessive need for ICU beds. Quick turnover creates extra movement in the ICUs, causing an increase in the particles in the air, possibly including microorganisms. Due to the pandemic, the study had to be shortened to 2 months periods instead of 3 as planned. Longer study period might have given better statistical results. On the other hand, we could strengthen the study in many ways. Hand hygiene compliance is audited and reported by infection control nurses regularly at our hospital. Compliance was reported as over 90% in both ICU from May to November. The differences cannot be explained by differences in hand hygiene compliance rates. Nonetheless, it should be kept in mind that the hand hygiene compliance is audited regularly but not continuously, which can still leave instantaneous failures open for discussion. Compliance to cleaning disinfection procedures is audited by infection control nurses regularly at our hospital, and all failures are reported using a corrective action form. There was no failure reported between May and November. The same staff performed cleaning and disinfection during this period in both ICUs, so the differences cannot be explained by thoroughness of the cleaning and disinfection. Rates of hospital-acquired infections may wax and wane over time due to the hyperendemic rates. But according to the hospital infection control surveillance data, there was no hyperendemic rate reported in any ICUs during the study period. So, if we come to the conclusion, the rate of infections identified in the ICUs increased as the number of colonies found in both ICUs increased. The microorganism concentration detected in the intervention ICU was lower than that in the control ICU. So, and at the end of these results, I can conclude that using air purifiers in addition to the hospital HVAC system may be an effective way to reduce the microbial load in the air and also on the surfaces to reduce hospital-acquired infections. I thank you very much for your attention. And if there are questions, I would be glad to answer if I can.
Thank you, Professor PERÇİN. That was fascinating. It's the second or third time I've seen it, and I've got something new out of it each time. What's striking for me is that you made very clear that the reduction in airborne organisms and surface organisms was reduced. It was your conclusion. Above and beyond what the ventilation system of the hospital was doing, because the ventilation system was working efficiently, I believe you said, the whole time. So that's a very interesting point. And it's an interesting point as well that the Klebsiella was reduced. That's a nice additional bonus for us, because it's not necessarily an organism that we've tested in vitro up to this point. So thank you, fascinating. I've got something new out of that every single time. And very well presented, concise and understandable. So we've got some time now, due to Professor PERÇİN's very effective use of time, for questions. Now, we had a whole range of questions in the last seminar, and I'm sure that we will get some questions this time as well from this group of people. So please, if you want to type any question or raise a hand, and we'll try to come to you and take the question that way. One more note, actually, just to refresh what I said at the start, for purposes of equivalence and understanding, the units in this test are internationally branded Novaerus units in the United States. Of course, we are working under the WellAir brand. And one other small difference, the 800, what we refer to as the 800 machine, in the rest of the world is the 900 machine in the United States, but otherwise the machines are exactly equivalent in performance, specification, etc. to each other. So that's just to help our United States colleagues and friends to make that equivalence. So any questions? Would anybody like any of the points that Professor PERÇİN made to be amplified?
I'm checking the chat part, but there are some congratulations, but not questions yet.
Can I mean, just to come back to what while we're waiting for some questions to come in, Professor, coming back to what we talked about at the start. Just coming back to what we spoke about at the start, were you surprised looking at the results that the air purifier, the Novaerus intervention, also reduced surface counts? Was that a surprising finding for you?
Yeah, I must say I was really surprised because as I told at the beginning, we are always following the CDC guidelines saying just cleaning and surface disinfection is enough, not for air disinfection. So I was so sure that there will be no help with the air disinfection for the hospital-acquired infection. But I mean, what I had was totally different. So I said, yeah, why not? Then we can maybe reduce the microbial load in the air in this way, and then afterwards, of course, if you clean the air, then there will be no particles falling on the surfaces, and no colonization on the surfaces, and then it can help to prevent hospital-acquired infections. Yeah, I was surprised. I was surprised to have something totally different than what I told all the time. So it's good to check it yourself.
Yeah. And would you say, I mean, that one of the main sources of contamination on surfaces is settlement out of the air? Is that a fair statement, or?
For me, we were always thinking that the most important thing is the patient and staff for the surface contamination. You know, patients are colonized and during the procedures and everything spreads in the near environment of the patient. But it can also be the reason that the air is contaminated, because we found those indicator microorganisms in the air as well. Yeah. So it means that it's also important.
Yeah, I would have one or two more questions up. Actually, I think we've had one or two questions and comments coming in.
Yes, so we have one from Fabiola Casas. I think, apologies if I don't pronounce the surname correctly. And Fabiola is saying it is important to define in these times where COVID has highlighted the importance of air quality, which methods are not only effective to kill microorganisms, but also to maintain environmental control and filter the air is essential. In addition to an adequate filtration system, what impact does the cleaning and disinfection of surfaces have on the prevention of infections? I think the question is, what impact does the cleaning and disinfection of surfaces have on the prevention of infections?
But for me, for the COVID, surface disinfection is not relevant. I mean, we don't receive, we don't get the infection through surfaces. We get it directly from the patient or with the hands or whatever, you know, touching your nose and eyes or whatever. So it's known as airborne infection. So it's important to disinfect the air more important than surface disinfection. So maybe this kind of disinfection method can be useful for the patient rooms to filter the air and also to disinfect the air. It can make it safer for the staff entering the room anyway. It's better than the surface disinfection.
We have another question from Raleigh. It says, excellent presentation. What type of financial benefit to a hospital would this type of data provide? Average cost of an HAI patient's extended cost, etc.
We didn't calculate the cost regarding to the hospital-acquired infection, but it's well known. You can find how much does it cost a patient bed in intensive care unit. It depends on the country and the hospital, of course, but you can easily calculate it, the difference from 5% to 0%. So it's almost zero infection. So it makes a lot different in that sense, because the intensive care unit beds are extremely expensive, let it alone the antibiotic cost and resistant microorganisms and the mortality rates. Just that I'm talking about the cost. It's expensive. I cannot tell you the price now. I cannot. We didn't do the cost analysis. We should have done it. In fact, when I see the question, it's really excellent question. We should have done it, but we didn't calculate. But it will certainly give a profit to the hospital. Certainly, if you diminish hospital infections, your hospital stay will be shorter, much shorter.
Yeah, and if I could just add to that briefly, again, depending on the system that you're in or the remuneration system, there are many countries, certainly in Europe, and I'm not sure how the system varies in the United States or parts of the Americas, whereby, for a particular procedure or a particular treatment or whatever, there is a fixed cost, awarded by the insurance company. So if you do get an infection in that situation and you go over, you have your hospital stay is increased. The hospital is actually losing money, significantly, because they're only going to get X for as remuneration for that particular procedure. So. Have we anything else coming in there, Selena? I did have another question, but I don't want to be talking all the time, so I hope that we will have one or two other questions. But I just asked them very quickly, just coming back to the organisms. You find a reduction in both the non-resistant and the resistant microorganism strains. Is that correct? They were both reduced.
Yes, they were both diminished. Yeah.
Which is
all kind of microorganisms. We don't have only resistant microorganisms. Also the normal flora microorganisms of the air and everything. We can count on all kind of microorganisms on surfaces and the air, but they all diminished.
Yeah, it has been historically difficult for us to collect that kind of data in the past. So that's a very interesting. And again, that's something I gained a better understanding of going through the presentation today. So that's very enlightening. Okay, we will. So if there are no more questions, well, that means I think perhaps the presentation was so enlightening that you answered everybody's questions, and they're all really content. So. General information, we have recorded this, so it will be made available to everyone to download, and it actually will appear, I believe that's correct, isn't it, Slaney or Jonathan? It will actually appear in the Teams discussion. You will get the link pretty soon after we close off.
Yes.
So you'll be able to, recycle it and go through it at your leisure.